standpoint, I think you might still have to check the red reflex. It is really difficult to do. You need an ophthalmoscope, and you take this little baby's eyes, and you basically kind of try to bring it over really quickly, and you're looking for the red disc, okay? If you don't see that, there's a concern that there might be a congenital cataract or something like that. I don't get too stressed about the red reflex. I don't consider it like a major behavior in clinical. Most of the time, the pediatrician will do that check, or the pediatric nurse practitioner. But I will say, it is fascinating with a brand new baby. They're very squinty, but when you turn down the lights, then they start to open their eyes. So if mom or dad or partner, somebody says to you, I want to see what his eyes look like, turn down the lights. If you turn down the lights, then a lot of times they'll open up. It's just the sweetest thing. They'll open up their little eyes and they'll just look at you so intently. Pupils should be equal, round, reactive to light. Sometimes they have a little bit of doll's eye. They might have one eye that kind of moves a little bit off kilter, but it's nothing to be alarmed by. We want to see that the cry, this term lusty, lusty means very deep, vigorous. They don't sound like a kitten. It doesn't like, it's not this real high-pitched, squeaky, soft cry. They're crying loudly, but they should be able to be consoled. If you have a baby that's crying and you cannot console that baby at all, unfortunately right now we're thinking withdrawal. We don't generally see those symptoms in baby at the first day of life. They aren't always going through those behaviors right then and there, but it's often after the first 24 hours. So they may be on a neonatal abstinence, neonatal abstinence screening after the first day of life. We want to see strong tone. Again, I think our book uses the term hypertonic. I know at Norton Women and Children's, they do not care for that term. When they think of hypertonic, they think of almost like seizure type activity. I think what the book is just trying to say is that there's a lot of tone and you should get resistance. So again, if you're trying to pull on the extremities, the baby should give you a little bit of fight. It should not be easy to extend the legs and the arms. That's all that hypertonic term means in the book. And then reflexes should be equal on both sides. We're not using our little patellar hammer when I talk about reflexes. I'm talking about things like Babinski and the crawl and the fencer pose and all those little fun reflexes that we do to kind of check babies. So trunk incurvation, those are always fun to play with the baby a little bit. The baby has a beginning period of reactivity that first 30 minutes after delivery. Now again, if the baby's stable, this is what you should see. If the baby's not stable, they're not with mom, they're going to NICU, okay? We're not gonna keep the baby there if they're in respiratory distress. They need intervention. So the first 30 minutes, we wanna try and get them to the breast. Not only does it help in terms of getting the signal to mom's body, hey, we need to make milk, so let's start working on that. The action of being on the breast is going to stimulate the endogenous production of oxytocin in mom, so it's going to cause her uterus to contract, so it's going to minimize her risk of postpartum hemorrhage. So even if mom doesn't want to breastfeed, I still would try to encourage her to put the baby to the breast. And a lot of times the baby doesn't do much. The baby might just be, and it just doesn't really suck as much, but just having the baby there, it's a signal to the brain, and it again activates all those hormones to help with uterine contraction. There we go. My brain is not working today. So after the first 30 minutes, then the baby gets really tired. So mom, after delivery, she gets really tired, the baby does too. The second period of reactivity, it's something that we as nurses need to be mindful of, because a lot of times that's when they're coughing up all that gunk on their stomach, they reflex their feeding, their vital signs kind of fluctuate here. And that's another reason why we wait a lot of times to do blood pressure, because if we do blood pressure in this second period of reactivity, we could get some kind of funky values. But it's kind of a risky time for the baby. So I would never put a new baby in mom's room and say bye-bye and not check on them for 4 or 6 hours. You should be rounding on mom regularly. You should be rounding on baby regularly. And that's one of the concerns, is that we have all this rooming in for baby-friendly hospitals. And so you've got a mom who's exhausted with a brand new baby who might be crying, is coughing up things, and mom is so tired, nobody's in the room to help her take care of the baby. Mom's in a lot of pain, she can't get up and attend to the baby's needs. So I think, there's kind of some concern about that. So as a nurse, I would want to, again, frequently assess them, check on them, provide a lot of teaching. Safety is paramount. You do not want a new mom sleeping in bed with the baby because we can have falls. They actually do falls precautions for newborns, believe it or not. And it's a lot of teaching with moms not to sleep with the baby. And so then after that period, again, the baby will have cyclical sleep. A new baby should not sleep through the night, okay? So generally, babies will have times where they're awake, they'll eat, they'll sleep, they'll pee and they poop, they wake up, they eat, they sleep, they pee and they poop. So it's kind of about every 2 to 3 hour, 3 to 4 hour. But I would never want a baby to sleep more than 4 hours at night. You need to wake the baby up and feed them, whether it's breastfeeding or formula feeding. Okay. So these are the behavioral states of the newborn. Deep sleep, REM sleep. With REM sleep, their eyelids are closed, but you'll see movement, and a lot of times they might be moving or having some activity in that sleep. Deep sleep, you can do all kinds of things to babies and they don't wake up at all. Again, that's when they have that bradycardia. Sometimes you may not get the reflex response in deep sleep, and that's, again, normal. It's not anything to be concerned about. Ideally, we would want to feed babies when they're wide awake or active awake. So wide awake is they often have their hands together, their eyes are open, and they're just looking, and they're very attentive, okay? Active awake, they're punching their little fists and their little legs, it's like they're trying to get somewhere, and they're trying to tell you all about it, okay? Both of those are really good. If you're trying to feed a baby who's crying, it usually ends up really bad for everyone involved. So it's better to kind of take care, change the diaper, kind of comfort the baby, wrap the baby, cocoon the baby, kind of get them to calm down a little bit, and then try and feed the baby. So we don't want them to wait until the baby's kind of screaming and crying a lot before they feed the baby. The new babies do not cry when they're hungry. Okay? They cry for lots of reasons. They might be hungry, but we don't want parents or caregivers waiting until the baby cries to feed the baby. In terms of sensory, the baby should have self-quieting behaviors. Some babies have actually sucked on their hand or their thumb in utero, and they'll have little sucking blisters, either on their hand or on their lips. So that's a normal thing. So if you have a baby who's, again, upset or crying, you just have them bring their hands up to their mouth, and a lot of times they can suck on that. You'll notice sometimes you might be holding the baby, and if the baby's breastfed, they kind of turn to your chest looking for something, and it's like, sorry baby, I'm not your mom, but they're looking for that, again, kind of quieting, comforting sense. And again, babies can smell who's their mom and who's not their mom, which is kind of cool. They actually take breast milk and use different types of breast milk, and the baby prefers their mom's breast milk, which I think is kind of cool. Donor milk, has anybody had donor milk for their baby? So we have some moms who make too much breast milk, and so they donate it to milk banks. And so some parents are choosing, rather than using formula, they're using donor milk to give their babies in the hospital. So I mentioned habituation. I did not mention. Habituation is I get exposed to the same stimuli. After a while, I habituate to it, which means I don't have that response. So in other words, initially some loud sounds and things, activities, I might see the startle reflex, but after a few days, I have less of that because I habituate to it. That's normal and expected. Babies who do not habituate or who do not have self-quieting behaviors, we are often concerned about drug withdrawal. Okay, prematurity would be another issue with babies who do not demonstrate those behaviors. Babies tend to see about 8 to 10 inches away, so we talk about from the crook of your arm to the face. They can't see across the room. They like contrast, they like faces. When you're dealing with babies, it's best to talk to them in a very soft tone and look directly at them, okay? Babies like to feel secure, so when you have a new parent, God bless you, you tell them to hold them very, very close, okay? Now sometimes new baby brothers and sisters, like don't drop the baby. They hold the new baby so close, it's like, okay, you're smothering the baby. So you have to kind of work and supervise to make sure that siblings are holding the baby appropriately. We're most concerned with the head. If I was working with a parent and a new baby brother or sister's holding the baby, I would want an adult to be there to hold the head, to make sure that the baby doesn't get dropped. Hearing, you are seeing hearing tests or hear about hearing tests for your newborns. They're pretty easy to do. We try to do it again when the baby's quiet. A hearing screening is merely that, is a screening test. If it's abnormal, they refer the baby to audiology. It does not mean the baby is deaf, okay? And we have a lot of false positives with our hearing screenings, but the idea is early diagnosis for early intervention. And then taste, are you using the little sucrose sweets for anything painful for your baby? So a lot of times before an injection, or circumcision, or blood draw, they'll give just a little bit of sucrose water, and that's kind of the natural analgesic. Wouldn't it be great as an adult if you could just have just a little bit of Kool-Aid? I feel so much better, but that works awesome in babies. So, my folks who had babies circumcised, did they give a baby any anesthesia for circ? Local? Good, yeah. So that's another thing that they used to not do at all. They did no anesthesia whatsoever. The thought was that by the time it worked, the circumcision was over. And then they found that babies who did get anesthesia actually recover better, like they return to their normal kind of behavior sooner than babies who do not get anesthesia, which to me seems like common sense, but we needed a study to figure that out, so. All right, so I want to talk a little bit about the Ballard scale. The Ballard scale has two pieces to it. So you have at the top neuromuscular maturity, and then you have physical maturity. There's a number, so it goes from -1 to 4 or 5, okay? And so what you would do is notice that what is not on the Ballard scale, there are no reflexes on the Ballard scale. So there's no stepping reflex, there's no startle, none of that. So when I look at neuromuscular maturity, I look at the little diagram. And when I usually do a Ballard, I do it in pencil because I want to kind of go back. And remember, it's really best to do this at delivery or within an hour after delivery, because some of our findings may not be as accurate if we do 2 or 3 days later. Now, we often have you all do Ballards on babies on all different kinds of ages, but I would not be, fussy if you had a slightly different result than what the Ballard they got at the time of delivery. So in this position, the baby's very flexed. You can see again extended here. Most of our babies are going to be in 4s and a couple of 3s. So you go down each criteria, and so a 4, a 3, a 4, a 4, a 4, and so on, okay? So I would just be familiar with what these are. So remember, I mentioned square window, okay? So in this is me, okay, I'm a baby. My wrist, my fingertips do not touch here. So I'm more of a preterm, so I would get more of like a 0 or a 1. I don't know, what do you think? That's pretty poor, I'm pretty low, okay? Scarf sign, how much can you bring the arm across the midline? In a term baby, you get a lot of resistance. When you try to bring that arm across, good tone. So when you look at scarf sign, again, you can kind of see it's like I can't really bring the arm past midline, but preterm, whew, super easy. So don't try to memorize degrees and all of that, okay? But I just want you to think conceptually about the picture of what a term baby looks like and what a preterm baby looks like. So in other words, popliteal angle. So their bottom is on the bed, I bring their leg up, I'm gonna get a lot of resistance. That angle underneath the popliteal space is less than 90 degrees. If I can take that leg and go whoop, they look like a gymnast or a ballerina, they're preterm, okay? So that's neuromuscular maturity. So if I have difficulty bringing the heel to ear, am I term or preterm? If I have difficulty bringing the heel to ear, I'm term. Does that make sense? Okay. All right. So the second part is physical maturity. So I have things like skin, lanugo, plantar surface, breast, eye, ear, genitals. Hopefully you can discern if you're, because sometimes you have ambiguous genitalia, so it's kind of hard to know. But most of the time you only score one of these, so either male or female. The other thing is, let's talk a little bit about lanugo. So you'll notice that lanugo on the far side, which is a -1, it says none. But if you go all the way, this is preterm, if you go all the way to the other side, it says mostly bald. So you're kind of scratching your head thinking, wait a minute, isn't that kind of saying the same thing? It kind of is. But you have to remember that if I have it here, then I also have sticky, red, friable skin. There's no creases on the heel. I don't feel any breast. So all of these things go together. You don't have a 4 over here and a -1 over here. So what I would say is most of your babies are going to have bald areas or be mostly bald. Again, our term babies are all going to be kind of right here, okay? So for example, am I a term baby or am I a preterm baby?
I'm term.
I'm a term baby. Because if I'm preterm, I'd stay. I'd be soft, there wouldn't be any cartilage. I have rapid recoil, okay? So I think, you know, again, you just kind of need, I think it's easiest to do this with babies, not nursing faculty. So when you're at clinical, look at different babies. I think you need to do a couple different, you can get your hands on a 36-weeker or a 37-weeker and compare to a 39 or 40-weeker, but it's very subtle, the differences that you'll see. For the breast, you're gonna need to palpate. You can't just look, you actually need to feel the breast tissue underneath your fingertips. And so a lot of times people are like, well, how do I know it's 5 to 10 millimeters? Like, we don't get a ruler out and measure it. It's just you have that judgment. And plus, if you're uncertain, well, is it 4 or is it 5? Well, again, where do you see more of the other data? It isn't gonna make or break our Ballard scale. Does it matter if the baby's 38 or 39 weeks with the Ballard scale? It doesn't matter, the baby's term. That's why we're doing the Ballard. The concern about the Ballard is the baby term or not? So when you look at the scale, only at 40 does the scale equal the weeks. So just because you get a score doesn't mean that's the baby's gestational age. You need to interpret your score. Okay? So this is square window, this is scarf sign, this is heel to ear. So we'll talk about the baby's genitals. So for a boy, the testes are down. When you palpate the testes, usually you want to have your finger over the inguinal canal. You're going to palpate each side of the scrotum, and you're going to feel, it feels like a really soft little pea. It's not hard, but that tells you that the testes are down bilaterally. And then you see a lot of rugate in the scrotum. It's very wrinkly. In term baby females, the labia majora are going to fully cover the labia minora. Is there anything about the Ballard? I think, again, you may not be real comfortable with this today, and that's okay, but really use the next 2 clinicals to be comfortable with it. You should be demonstrating a Ballard and documenting one and turning that into your clinical instructor. It's a clinical requirement.